Biju sir, shall we start the session?
Yeah, no problem.
Okay, sir. Good afternoon. Welcome to the third session of the Pushpagiri Medical College webinar series being conducted as a part of the annual CME program from the Department of Community Medicine. Our theme is Resolution of Paradox, Solving the Conventional Concepts of Liability and Validity. The series of 4 sessions. 2 sessions we completed. First one was on Understanding the Lab Test in the Wake of COVID-19 Pandemic by Dr. Manasi Ravikranath. Second was on Reliability versus Validity, often a trade-off by Dr. Devraj. For those who have missed, the sessions are available in Pushpagiri Community Medicine YouTube page. Today's topic is on Predictive Value versus Likelihood Ratio by Dr. Biju George, Associate Professor in the Department of Community Medicine, Government Medical College, Calicut. He did his MBBS and MD in Government Medical College, Calicut. He did PG Diploma in Applied Statistics and Applied Population from Gandhigram Rural University. Also, he did MPhil in Clinical Epidemiology from Kerala University of Health Science. He was a postdoctoral research fellow at the University of Western Ontario, Canada. He has worked as faculty for clinical research Kochi. He is a member state operational research committee RNDCP Kerala State. He has around 63 journal publications in his name. It is our privilege to have you for the session. I welcome Dr. Biju George, sir. Please leave your comments and questions in the comment box. We will discuss it at the end of the session. Over to you, sir.
Thank you. Okay. Is the screen visible and am I audible?
Yes, sir.
Okay, so we can start probably, or should we wait for some more?
We wait for 5 more minutes, sir, so that some more can join the session.
Okay. Okay. Dr. Mary, shall we start?
Yes, sir. We can start.
Okay, so thank you. So first of all, thanks the Pushpagiri team for inviting me to talk on these subjects. Now, before the actual presentation begin, if any of you have any doubts during the presentation, you can just stop me and ask your question. That sometimes that may be important because when I'm talking, if you don't get an idea, sometimes you will get lost in the next steps. So if you have some pressing doubts, please do ask. Don't hesitate, just please do ask. Now, if you think your doubts can wait a little bit, you can put it in the chat box so that we can look into a chat box in the end and address these queries also. So let me start by what I'll discuss basically. I know that in the last class, Dr. Devraj has already talked about validity and other things. But I will also touch upon a little bit amount of sensitivity specificity, then move on to the predictive value. A little bit details about the likelihood ratio, one slide about the diagnostic odds ratio, a few slides about the ROC curve, and basically the concept about the probability which we use for the treatment purpose. So you already know that validity is basically a measure of truthness. Now we are talking about validity in the context of some laboratory test or some test to detect certain diseases. So its ability, it is basically the ability to distinguish between those who have the disease and those who doesn't have the disease. And always we are comparing a test against a standard test. So that test, which is many often a new test, but sometimes it can also be an old conventional test also. But that test is always compared against a standard test. And that standard test is called as a reference standard or the criterion standard. The old terminology was the gold standard. The current terminology is basically the reference standard or the criterion standard. Now, when you talk about criterion standard, you should keep few things in your mind. Now, most of the criterion standards are usually very costly tests, or they are generally very invasive tests, like histopathology examination. To do a histopathology examination, many often you have to do biopsy, and that involve a lot of invasive procedures. Or many of these criterion standards are resource intensive, and because of it, it's very difficult to perform. One of the assumptions that we always make when you do a diagnostic test evaluation, in most of the situation, we do make that assumption that criterion standard will correctly categorize the participant into diseased and not diseased people. Now that assumption is very essential in our traditional calculation, because if you assume that criterion standard is not a perfect criterion standard, then you cannot use the traditional diagnostic evaluation methodology. You have to use some kind of a Bayesian methodology or a latent class analytic techniques to do the analysis. So in the usual diagnostic evaluation technology, we make an assumption that the criterion standard is perfect and it correctly categorizes the subjects into those with the disease and those without the disease. So that means criterion standard has 100% sensitivity and 100% specificity. And another criteria that we generally use for criterion standard is criterion standard will dichotomize all the participants in the study into correctly into diseased and those without the disease. That means the categorization is in a binary format. That may not be true in all the situations. Sometimes the criterion standard may categorize into disease, not disease, and indeterminate. But for all the analysis purpose, we may have to push the indeterminate to either a disease group or the not disease group and make it binary. So these two assumptions are very important. One, criterion standard correctly categorize subjects. Second, criterion standard basically dichotomize participants into diseased and not diseased only. A new test, if you look, it can be a lab test. And most of the diagnostic evaluation, when we talk, we generally talk about the lab test. But also remember that the new test can be a symptom, a sign, clinical sign we elicited on examination. So any part of a history or a clinical examination can actually act as a test. And its sensitivity, specificity, predictive values, etc., can be calculated against a criterion standard. And general assumption is these new tests are either cheap, they are less invasive, less time consuming, and easily doable tests, which is why we try to use this as a replacement for the gold standard or the criterion standard. Now, the new test can give the results either as binary or maybe ordinal or as a continuous format. So the new test need not be binary itself. It can be in any results can be obtained in any format. It doesn't create much of a problem. You have different ways of analysis for that. Now, you may have seen this table even before this presentation. And few of the things in this table you should be really keep in your mind. The criterion standards are generally, the results of the criterion standards are generally given in the vertical axis, because the criterion standard or the gold standard is the final thing. That is a definite thing. So they are generally given in the vertical axis. The new test results are generally given in the horizontal axis. And then you have the A, B, C, and D as the cell counts. Now, if you interchange the rows and column, there is no problem. Only thing is, if you interchange, your calculation should move appropriately in a different manner. Now, but generally, in an epidemiological sense, your criterion standard or your final outcome is always in the vertical axis and the new test results are in the horizontal axis. Now, one more thing you should keep in mind is the A plus C. Now, A plus C subjects out of the n number of subjects is having the disease. So A plus C divided by n basically gives the prevalence of the disease, or sometimes it is called as a pre-test probability. So it gives the probability of a disease even before the new test is applied. Even before the new test is applied, what is the probability of the disease or the prevalence of the disease in the condition? Okay, now this table can be analyzed in different manners, and that's where you have the sensitivity, specificity, positive, negative, predictive value, and the likelihood ratios, and maybe other reliability measures like total agreement, kappa, etc. all appear based on the way in which you analyze this table. Now, if you are trying to analyze in a vertical manner, that means this manner, then what you find is you have A plus C subjects who have the disease. You have A plus C subjects, A plus C number of subjects who have the disease, out of which A number of subjects is test positive. So that is A number of subjects is test positive out of the A plus C subject who are really diseased. And that gives you the sensitivity. That gives you the sensitivity. Okay, now in the same manner, if you are looking at the second column, there are B plus D subjects. B plus D subjects who are normal or disease-free. So if you test in a disease-free subject, we want our result new test to be negative. And out of the B plus D subject, D number of subjects are test negative. So that D divided by that B plus D basically gives the specificity. Okay, so sensitivity and specificity are based on a vertical analysis, and they are two important components of validity, as you have already learned. And sensitivity is the ability of a test to give positive result among the disease subject, and specificity is an ability of a test to give negative results among those without the disease, among the normal group. Now let us, you can also try it along with me. Let us try to calculate the sensitivity and specificity of this particular table. So you have 100 disease subjects, out of which 80 were test positive. So your sensitivity is 80 by 100, which is 0.8. For easiness, we'll say 80%. Now, what is that meaning? What is the meaning out of that 80%? It actually means that 80% of the disease subjects would be correctly categorized as test positive, would be correctly categorized as having the disease by the new test. Okay, now what is the specificity? There are 900 subjects without the disease, out of which 800 were tested negative. So 800 out of the 9,000. That would give you 88.9%. So you can approximately say 89%. So what does it mean? 89% of the normal subjects would give a test negative result. Gives a test negative result. Okay, so sensitivity and specificity you have already learned. And remember, this sensitivity, specificity, these are dependent on the test. That means whatever is the material in the test, they decide the sensitivity, specificity. So the material in the test, you can tweak it so that you can have a higher sensitivity or a higher specificity. And in generally, your sensitivity is inversely related with your specificity. So as the sensitivity increases, many often your specificity will decline. It may not decline to zero, another thing, but specificity will decline from the higher value. Now, that is true for most of the situation. There are few exceptional tests which has extremely high sensitivity and specificity also. Very classical example is that kind of a ELISA test that is available for HIV, which both the sensitivity and specificity are more than 99%. Both sensitivity and specificity, both are more than 99%, like 99.5% and 99.9% generally, depending upon the kit. But both are like more than 99%. So that is one exceptional test which has both very high sensitivity and specificity. But most of the other tests, if you look, they have either high sensitivity, a moderate specificity, or they have very high specificity, but a moderate sensitivity. Traditional teaching is that your sensitivity and specificity are not dependent on the prevalence of the disease. So if you do the test, if you do a diagnostic evaluation study in a peripheral outpatient department of, let us say, a GP, or if you do the same study in an outpatient department in a tertiary hospital, the prevalence would be very different. In a GP's clinic, prevalence for, let us say, dengue fever, the prevalence for dengue would be very low there. The prevalence of dengue in a tertiary care setting would be very high. But the sensitivity specificity would remain same. That is the traditional teaching. But there is something called as a spectrum effect or a spectrum bias. And that spectrum bias can have an effect on the sensitivity specificity. Remember, all the diseases have spectrum. Now, dengue fever, if you are studying, let us say, in a GP's clinic, most of the dengue fever patients, that spectrum of the dengue fever patients should be mild dengue fever patient only, without any other complications, without any dengue hemorrhagic symptoms or other things, etc. Or the severe variety of disease would be very negligible. But if you are studying dengue fever probably in a tertiary care center, the spectrum changes into a higher grade spectrum. The lower grade spectrum may be absent here, or maybe very minimal here. And if the spectrum of the disease changes, because there is a prevalence difference in these two groups, and if the prevalence changes, the spectrum also changes, then that spectrum can have an effect on the sensitivity and specificity. If the prevalence changes and the spectrum of the disease remains same, sensitivity specificity will remain same. But if the spectrum changes along with the prevalence, then the sensitivity and specificity would be affected because of that. Now that's about the sensitivity specificity. Now let us look at that table again. Now in this time, let us look in the horizontal manner. If you look in the horizontal manner, there are A plus B test positive subjects. There are A plus B test positive subjects. Out of the A plus B test positive subject, a number is disease positive also. So A divided by A plus B will give you the positive predictive value. Out of the A plus B test positive subject, a number of subject is disease positive. So A divided by that A plus B will give you the positive predictive value. Now, same manner, there are C plus D subject who are test negative. Out of the C plus D subject who are test negative, D number is disease negative also. So D out of that C plus D would give you the negative predictive value, NPV. So what is positive predictive value? Very simple. Probability of the disease among the test positive subjects. Probability of having the disease among the test positive subject. Among the test, if you have 100 test positive subject, what percentage of them is having disease? That is the positive predictive value. Negative predictive value, probability of not having the disease or probability of being normal among the test negative subjects. So if you have 100 test negative subjects, what percentage of them are really normal or what percentage of them are free of the disease will give you the negative predictive value. Now, let us calculate positive and negative predictive value in this table and then try to interpret these values also. Now remember, positive predictive value out of the horizontal axis. So these are the two things. So 80 divided by 180. So 80 divided by 180, that gives you 0.44, 44%. Now what does that 44% mean? It basically means that out of the 100 test positive subjects, 44 of them will be disease positive also. But that also means that 100 minus 44, that is 56 or 56% for that matter. Even though they are test positive, they don't have the disease. So this means this positive predictive value, even though this positive predictive value, this is 44, this is not sufficient to confirm a disease. We want our positive predictive value to be very high. Ideally, what we want would be maybe 100%. But we all know getting 100% is very not a very realistic thing. But probably we want our positive predictive value to be 90% or maybe at least around 80% for most of the disease. And maybe in certain condition, we may even accept probably 70% positive predictive value. Now, this test, you say 44% positive predictive value. Now, what will you do further? We cannot confirm the disease here based on this, which means you have to do some further testing of the subject so that the final positive predictive value changes from that 44% to something like more than 80% or more than 90%, so that we can confirm that there is a disease and start treating the patients. Same way, negative predictive value, here there are 820 test negative subjects, out of which 800 is disease free. So 800 out of the 820 will give you 0.976, 97.6%. So if you are a test negative, there is 100 test negative subjects, almost 98 of them will be really free of the disease, will be really normal. And the rest 2% only would be a false negative subjects. False negative subjects. So negative predictive value here, practically we can rule out here that they don't have the disease and we can just send them home, provided we just assume that this is sufficiently good negative predictive value for that disease. Now, if the disease is very life-threatening and if you don't treat, it will definitely lead to death and very severe morbidity and will lead to lot of cost. You may want a very high negative predictive value. But if the disease is not much severe, very light disease, probably you can have a lesser negative predictive value of probably 80% or a 90% also. Now, there are certain formulas to calculate positive predictive value and negative predictive value based on the sensitivity, specificity, and prevalence of the disease. So I have just given that formula. You can later on calculate this, and then you can find that this is that positive predictive value is basically A by A plus B. And if you solve this equation, you will finally end up with that A by A plus C. Same way, if you solve that D by C plus D, if you solve this equation, you will finally end up with that D by C plus D. But if you don't want to put a table and if you want to put it as a formula into some program so that you can calculate positive predictive value, once you plug in the sensitivity, specificity, and positive predictive value, these are the formulas to use that. Now, here you will immediately see that both positive and negative predictive value, both are affected by sensitivity, specificity, and prevalence. But the influence is different. Now, let us look at the case of positive predictive value. Let us first look at the effect of prevalence. Let us first look at the effect of prevalence. We look at a very high sensitive and specific situation. Very high sensitive and specific situation we look, and then look how the prevalence change. If when the prevalence change from 0.5% to prevalence, 80% prevalence, how the positive predictive value changes. So from 4 to 97, the positive predictive value increases. So immediately you will know as the prevalence increases. So if the prevalence increases, that will immediately lead to increased positive predictive value. So prevalence is one of the major determinant of the positive predictive value. So and any small increase in the prevalence generally lead to an increase in the positive predictive value. But even though what I said is correct, you will also notice that a small increase in the if the prevalence increase up to, let us say, up to here 5% or up to this part, the increase in positive predictive value is small value actually from 4 to 8%. Or if you look from this to this, from 50% prevalence to 80% prevalence, the positive predictive value increase from 90 to 97. So what does it mean? The prevalence is a major determinant, but if the prevalence is, let us say, less than 10%, or let us say if the prevalence is, let us say, more than 80%. So if the prevalence is less than 10% or more than 80%, probably the predictive value doesn't change that much. The predictive value change very drastically if your pretest probability or the prevalence is somewhere between 20 to 80%. We will come to that concept later on, once again later on. Now, so that's one thing. Now, second thing that we can look is whether the sensitivity or the specificity influence the positive predictive value to a larger extent. So let us fix at one prevalence, 20% prevalence. And if you look at the first row, this table, the sensitivity increases. Sensitivity increases from 30 to 90%. But the specificity, it remains the same, 90%. Second table, your sensitivity remains same, but specificity increase from 30 to 90%. Now, same thing, look at how the positive predictive value changes. When the specificity changes, so in this table, basically the specificity changes. So when the specificity changes, the positive predictive value changed from 24 to 69%. Here, when the sensitivity changes, same amount, the positive predictive value changed from 43 to 69. So there is a much bigger increase in the predictive value here. So specificity is more determinant of the positive predictive value than a sensitivity in general. So prevalence and specificity, when it increases, positive predictive value increases drastically. And the sensitivity increases, positive predictive value also increases, but to some extent only. Now, the same concept we can see if the prevalence of a disease is 50%, 50% is having disease and 50% is not having disease, your positive predictive value is basically this segment divided by this segment. So these are almost equal. So you'll get a equivalent positive predictive value. But if your prevalence increases, then what happens is this segment become very large, disease subsegment become very large in number compared to this segment. So when you divide it, you have a very high positive predictive value. So when the prevalence increases, you have an increase in the positive predictive value. Now, the other thing, the sensitivity. If the sensitivity, so this is more of a sensitive test, only this much is missed. If it's a very sensitive test, then this segment divided by this segment will give you the positive predictive value. Because this sensitivity is increased, you have an increased positive predictive value. Same way, if you have a high specificity, and that lead to a very increase in the positive predictive value compared to the negative predictive value. Now, so that basically gives you the acronym, the snout and the spin. So what it say, snout basically say, if you have a high sensitivity and if you get a negative test result, if you have a high sensitivity, if your test is highly sensitive and if you get a negative test result, you have a very high negative predictive value and you can use it to rule out the disease. If you have a very high, let us say, if you have 100% negative predictive value, if you get a negative test result, you are sure that they are free of the disease. They are free of the disease. They don't have the disease, that we are sure. So you can just rule out the disease. And the spin, which basically means that if you have a high specificity, if your test is highly specific and you get a positive test, then you have a very high positive predictive value. And then if your positive predictive value is, let's say, close to 100, if you get a positive result, you are sure that they do really have the disease and they can be used to rule in, to confirm the disease. The other one, high sensitivity test, can be used to rule out the disease. The spin and the snout are the two acronyms to relate the sensitivity, specificity, and predictive value with ruling in and the ruling out. Now, you can also do a vertical analysis. Instead of the sensitivity, specificity, you can do a vertical analysis in a slightly different manner. Here, you can actually look at, there are A plus C subjects with the disease, out of which A is test positive. So A plus C subjects are disease positive, out of which A is test positive. So that gives a probability of test positivity among the disease positivity. Test positivity, probability of test positive among disease positive. So probability of the test positive among disease positive is A by A plus. Now, same way, you have B plus D disease negative subjects, and among them, B number of subject is test positive. So you have B by B plus D. So that gives you a probability of test positive among disease negative subjects. Probability of test positive among disease negative subjects. Now you can divide this with this. That means A divided by A plus C divided by B divided by B plus D. And that basically gives you the likelihood ratio. So what is positive likelihood ratio? Probability of a test positive among the disease positive divided by the probability of test positive among the disease negative subject. So for a positive test, if you calculate likelihood ratio, so test positive among the disease positive divided by test positive among the disease negative. If you are calculating a likelihood ratio for a negative test, probability of test negative divided by disease positive divided by test negative among the disease negative subjects. Now, this is equivalent to this, sensitivity divided by 1 minus specificity. Why the likelihood ratio negative is equivalent to this, 1 minus sensitivity divided by the specificity. Now, let us calculate a likelihood ratio for the situation and then try to interpret what is the meaning of that likelihood ratio. Now, likelihood ratio for a positive test is the probability of test positive among the disease positive. Test positive among the disease positive. Probability of test positive among the disease positive. So that is 80 divided by 100 divided by test positive among the disease negative subject. Test positive among the disease negative subject. So this will give you, sorry, I think 7.2 as the positive likelihood ratio. Now, same way, if we calculate the negative predictive value, probability of a test negative among the disease positive subject divided by probability of a test negative among the disease negative subject. So probability of a test negative among disease positive divided by probability of a test negative among the disease negative subject. So 20 by 100 multiplied by 900 by 800. So 83. 18 by 80. So 18 by 80 will give you 0.225. 0.225. Now, positive predictive value 7.2 and negative predictive value 0.225. What does this mean actually? So, if you are a test positive subject, test positive, then what does it actually mean? So this 7.2 is a ratio. 7.2 is a ratio. So always when you think it like 7.2 is basically 7.2 is to 1. So what is this 7.2? This 7.2 is probability of test positive among the disease positive subject. And what is this 1 actually? Probability of test positive among disease negative subjects. So you have 7.2 times higher chance of giving a test positive result. You have a 7.2 times higher chance of getting a positive result among the disease compared to non-disease subjects, compared to normal subjects. 7.2 times higher chance of getting a positive result among the disease subjects compared to normal subjects. Now, what about this 0.225? So that 0.225, that 0.225 should also be considered like a ratio. 0.225 is to 1. So this probability of test negative among the disease positive subjects, and this probability of test negative among the disease negative subjects. So your chance of test negativity in the disease subjects is only 0.225. The chance of test negativity among the disease positive subjects is only 0.225 compared to the chance of test negativity among the normal subjects. So compared to normal subjects, the disease subjects has a lesser chance of getting a negative test result. Okay, so these are the likelihood ratio and their interpretations. Now, how large should be a likelihood ratio for a good test? Now, if you are talking about positive likelihood ratio test, a likelihood ratio, the traditional classification is any LR more than, any positive LR more than 10 is considered as a very good test. Something between 5 and 10 as moderate, between 2 and 5 is mild, and anything between 1 and 2 as not good. And if the likelihood ratio is equivalent, 1, it is equivalent. So if your positive likelihood ratio is 1, it is 1:1. Your probability of giving a test positivity among the disease compared to a not disease is only 1. So that basically means disease positive and disease negative subjects are equally likely to get a test positive result. So any LR1 basically indicates the test is not good at all. Not good at all. It is insensitive test. It's not good for confirming. It is not good for ruling out. Not good for ruling in or not good for ruling out. If you are thinking about negative likelihood ratio, these values would be something like this. Reverse of the positive likelihood ratio. So 10 basically gives 1/10, which is equivalent to 0.1. 5 basically 1/5, which is actually 0.2. So just like the odds ratio, when you reverse, protective odds ratio become a risk portion. Same way, likelihood ratio, when you take reverse, the same cutoffs are applied for the negative likelihood ratios also. Now, you may have heard about the criteria, the equation relating the pre-test odds and the post-test odds. Now, equation is something like this. Your pre-test odds multiplied by your likelihood ratio gives the post-test odds. Now, what is pre-test odds? You have heard about pre-test probability. Remember, we talked about pre-test probability or the prevalence of disease in the initial part of the discussion. We said A plus C subjects, if you are looking at A, B, C, D, and we said A plus C subjects divided by the total number gives the prevalence of the disease or the pre-test probability of the disease. Once you get pre-test probability, you can convert it into odds. Or if you have the odds, you can convert it into probability. So these are the basic equations for converting it. Okay. Now let me give you a way to tackle how to convert from probability odds or from odds to probability and vice versa, etc. Let us take a case of 10 persons. Out of this 10%, 6% is disease positive, and the rest 4% is disease negative. Okay, this 10% out of this 10%, 6% is having the disease, 4% does not have the disease. So can you calculate what is the probability of disease? What you calculate? What is the probability of disease? ഒന്ന് കാൽക്കുലേറ്റ് ചെയ്തിട്ട് എത്രയാണെന്നുള്ളതൊന്ന് ചാറ്റ് ബോക്സിൽ ഒന്ന് ഇടുക. What is the probability of disease? സിമ്പിൾ കാൽക്കുലേഷൻ ആണ്. 10 പേരുണ്ട്, അതിൽ 6 പേർക്ക് ഡിസീസ് ഉണ്ട്, 4 പേർക്ക് ഡിസീസ് ഇല്ല. So what is the probability of disease in this group? Yes, so Vivek was saying the probability of disease is 0.6 or 60. It depends upon whether you are talking in terms of a fraction or percentage. So how did you calculate? This is 6 out of the 10. 6 out of the 10, and which gives you the 0.6 or in percentage the 60%. Okay, so if you know that there are 10 people 6 are deceased, 4 are not deceased, you immediately know what is the probability. Now, how do you calculate odds? Odds is, think it like this. How many people, odds is a ratio where the numerator is how many people have the disease or what percentage have the disease. So out of this 10 people, how many people have the disease? 6% have the disease. Now the denominator part is how many do not have the disease. So out of the 10%, how many do not have the disease? 4 didn't have the disease. So your odds is 6 by 4 or 1.5. Odds is 6 by 4 or 1.5. Now remember that 1.5, you should in your mind always read it like this. 1.5 is to 1. That means if you have one person without the disease, then you have 1.5 persons with the disease. So if you multiply it with 4 on all sides, you have 4 persons without the disease and you have 6 persons with the disease, 6:4. And that 6:4 is the same here. 6 persons with the disease and 4 persons without the disease. So 6:4, that gives an odds of 1.5. Now, let me say the odds of a disease, it was 5 by 6. Suppose say odds of a disease was 5 by 6, or let me say 3 by 6 for easiness. So 3 by 6, you can write it as 0.5 also. So 3 by 6, you can write it as 0.5 also. How do you convert this odds into probability? Now, there are two ways. If it is in the fraction, just look at the fraction. 3 by 6 is basically 3:6. 3 people with the disease, 6 people without the disease. 3 people with the disease, 6 people without the disease. So if that means there will be altogether 9 persons. Altogether 9 persons. So what would be the probability? 3 persons with the disease out of the 9 persons. That would give you a 33% probability or 0.33 as the probability. Now the other way you can look is if odds is already given as a fraction, 0.5. So if you are looking at 0.5, you should consider that 0.5 is 0.5 divided by 1 or 0.5:1. 0.5 is this with the disease, 1 is without the disease. So altogether there are 1.5 persons. And probability would be, means 0.5% with disease out of the 1.5, that would give you 33% or 0.33. So if you have the odds, you can very easily convert it into probability. Or if you have the probability, you can convert it very easily into the odds also. Now, what is pretest probability? Pretest probability is nothing but prevalence of the disease, as I have mentioned it already. And what is post-test probability? That is the prevalence of a disease after you do the test and you get a positive result. After you do the test and you get a positive result, you get prevalence of a disease. That is what basically we call as the post-test probability. Or post-test probability is basically the positive predictive value itself. Positive predictive value itself. Now let us calculate one exercise. Let us calculate. So remember the formula is pretest odds into likelihood ratio is basically the post-test odds. So first we have to have pre-test probability that has to be converted into post-test odds, and in the end, post-test odds has to be converted into post-test probability. Okay. Now, what is the pre-test probability? We already say it is 10%. 10%. 10% is basically 0.1. 0.1. 0.1 or 1 by 10. 0.1 is basically 1 by 10. So that is the pre-test probability. So can you convert this pre-test probability into pre-test odds and tell me what would be the pre-test odds? Your pre-test probability is 1 by 10. So what would be the pre-test odds? Can you calculate and put it in the chat box? Remember, 1 by 10 basically means 1% out of the 10% is having the disease. That means 9% does not have the disease. So now immediately you have the odds coming in. 1:9 or 1 by 9 would be your odds. So this is 1 by 9. Your pre-test odds is 1 by 9. Now, what is the likelihood ratio? You already given it as 10 here. You already given it as 10 here. Sorry, already given here as 10. So into 10 will give you 10 by 9. So that is your post-test odds. So your post-test odds is 10 by 9. And then this you have to convert into post-test probability. So 10 by 9 is your post-test odds. Post-test odds. So 10 by 9 is 10:9. So that means out there are 19 people, 10 people is having the disease, 9 people is not having the disease. So what is the probability now? So your probability of disease is 10 by 19. 10 by 19. So that 10 by 19 will give you around 0.53. This will give you around 0.53 or 53% as the post-test probability, or positive predictive value as the 53%. 53% may not be sufficient in most of the situation. Okay, let us move forward. Now, many often you don't stop with this 53%, because 53% positive predictive value means you are not very sure that the person is really having the disease. So you want to increase the positive predictive value from 53% to probably like 80% or more. So how do you do that? You add among the positive subject, you do another further test, or if you get a negative result, you do another test on that. So once you calculate pre-test probability, that gives you a pre-test odds. You apply a likelihood ratio for first test, that gets you the post-test odds for that test. And that post-test odds become the pre-test for odds for the second test. Apply a likelihood ratio and then that gets the post-test odds. So what happens is you can write pre-test odds into likelihood ratio of test 1 multiplied by the likelihood ratio of test 2 multiplied by the likelihood ratio of test 3. That will give you the final post-test odds of after all these 3 tests. And then, so from these pre-test odds, you can directly multiply all the 3 likelihood ratios, and that will give you a post-test odds, and that finally convert into a post-test probability. Now, let us calculate solve based on this. Your pre-test probability is same 10%. You have 3 tests with corresponding positive and negative likelihood ratio. And test 1 gives a positive result, and then you do the second test after you get. Second test gives a negative result. So you are scared, you did a third test, and the third test give you a positive result. Now, after these 3 tests in a serial manner, what is the post-test probability? So same thing, your pre-test probability is 10%. So pre-test probability is 10%, which is 0.1, which is 1 by 10. Now that I have to convert it into pre-test odds, which is 1 out of the 9. Remember, 1 is having the disease, 9 is not having the disease. Out of the 10, 1 is having the disease, 9 is not having the disease. That is 10% prevalence. So odds should be those who have the disease divided by those who do not have the disease, 1 by 9. So pre-test odds should be 9. So pre-test odds 1 by 9 multiplied by the likelihood ratio for first test, because the likelihood ratio for first test was positive, first test was positive. So we have to use the likelihood ratio for first test, positive likelihood ratio for first test, 6. Now the second test was negative. So we have to use the negative likelihood ratio only, 0.6. The third test was positive. So we have to use the positive likelihood ratio for that test, 2. So these 3 tests together, if you just look at the 3 tests together, the total likelihood ratio of these 3 tests together with that corresponding result, positive, negative, positive result together is 7.2. And that 7.2 into 1.9 will give you a post-test odds of 0.8. So this is your post-test odds. Now that 0.8 is always 0.8 is to 1. That means out of the 1, this is positive and this is your disease negative. So out of the 1.8 people, 0.8 people have the disease and 1 person didn't have the disease. So you can easily convert post-test probability, post-test probability, which is equivalent to 0.8 divided by 1.8. 0.8 divided by 1.8 will give you 0.44 or 44% as the post-test probability. 44% as the post-test probability. So you can do multiple tests, and if you know the positive and likelihood ratio of each of these tests, and if you know after each test whether it was a positive or negative, you can just multiply the likelihood ratio, corresponding likelihood ratios for these tests, and then get the total likelihood ratio for that test set together. Now, very often people will find it very difficult to do all these kinds of manual calculations. So there were a lot of attempts to reduce these issues of calculation. One such method was Fagan's nomogram. Let us say we have a pre-test probability 10%, and our likelihood ratio for the test was 10%. That means 10. So if you look at this Fagan's nomogram, and if let me draw a line. Okay, so that right line probably goes into that post-test probability around somewhere around 55% probably. If you remember, we had a calculation, 10% prevalence, likelihood ratio of 10, and our positive predictive values came somewhere around, I think, 53% or something like that. So this somewhere around that value. So this will give you a rough estimation. Fagan's nomogram will give you a rough estimation. Now another easy method which is suggested by Maggie et al. It was to something like this. If your likelihood ratio is 10, you add 45% to your pretest probability. For example, your original pretest probability was 10%. You add a 45%, and your final post-test probability or the positive predictive value become 55. So that's somewhere closer to that value you obtain. For likelihood ratio 2, 15%, likelihood ratio 3, 20%, likelihood ratio 4, 25%, likelihood ratio 5, 30%, likelihood ratio 6, 35%, likelihood ratio 9, 40%, and likelihood ratio 10, 45%. These were the values given by the McGee. But now you have a lot of small softwares which if you give your pretest probability and LR, it will automatically calculate and give you the post-test probability. So there are a lot of small apps which are available to do all these kinds of operations. So probably these Sagan's nomogram, McGee's technique, etc., become of less use now. Now, what if the test is a continuous or ordinal one? Because likelihood ratio, sensitivity and predictive value, they are calculated only for those tests where it converted into a binary variable. Now, if the new test gives it in a continuous or ordinal manner, then what can be done? We cannot calculate predictive values of sensitivity. We can only calculate likelihood ratios. Now, the likelihood ratios can be calculated in two different manners. The situation can be dealt in two different manners. Now, one option is to dichotomize that continuous and ordinal variable using a cutoff. And so if you just dichotomize at one point, it will give you one set of sensitivity, specificity, positive, negative, predictive value, and likelihood ratios for that. But you can dichotomize at different cutoffs. You can use different cutoffs and dichotomize based on these cutoff, and they will give you the sensitivity, specificity, negative, positive, negative values for a set of cutoffs. For each cutoff, you have a set of sensitivity, specificity, positive, negative, predictive value. And then based on it, you can decide which cutoff is the most suitable one. That is one option. The second option is you don't categorize. For each level, if it's an ordinal, if it's a continuous, probably you will have to convert it to some ordinal one. For each level, you can calculate likelihood ratio. We will see both of the techniques. For that technique, let me show you one result. This test is CPK values done among subjects with chest pain, and subjects were evaluated with other techniques, ECG and troponin, etc. And then they decided whether their subject is having MI or no MI, etc. Now, out of the 1,000 persons studied, 200 were having the MI. 20% is the prevalence of MI. Let us say this is in a tertiary care setting where those with the chest pain, around 20% may be having MI. Now, this is a table that we obtain for each category of the CPK value. Now, if you want to dichotomize, you can dichotomize at this level. So it becomes one table like this. So this is 200, this is 80, this is 10, this is 4, this is 796, and this is 190. And for this table, you have a sensitivity, specificity, positive predictive value, negative predictive value. And even you can calculate LR also for that particular table. Now, you can also you can also do a cutoff. Let us say you can also do a cutoff at this level. So if you do a cutoff at this level, this would be your values. So this would be 14, this would be 12, this would be like a 186, and this would be like a 788. And for that set, you have a sensitivity, specificity, positive predictive value, negative predictive value, LR positive, LR negative. And then suppose you put a cutoff here, and for that cutoff, you will have another table. So that would be, so sorry, this would be 20, not 14, this would be 24. Okay, and this 24, 40, this would be 42, and this would be 24. This is 200, 800, and this would be like a 158, and this would be 176. And then corresponding, you will have a sensitivity, specificity, positive predictive value, negative predictive value. So you can calculate for this is more than or equal to 200. This is more than or equal to 190. This is more than or equal to 190. For each of these cutoffs, each of these dichotomization, you will get one sensitivity specificity values. And that is what is given here. So this is like more than, you can consider it like this. This value you can just ignore. These are all in terms of cutoff values. Okay, so, and I have given you the for each cutoff what would be the sensitivity and specificity, etc. I have also given the positive likelihood ratio. The likelihood ratio may not be, that table for likelihood ratio may not be much of importance here, but sensitivity specificity can be used. And then based on it, you can decide what is your optimum sensitivity and what is your optimum specificity. And then based on it, you can make a decision. But many often, you will use this information and create something called as an ROC curve, which we will talk a little bit later. And then decide, we can decide what would be the best cutoff based on the ROC curve. So that is the first approach. The second approach is not categorizing. Instead, we'll use each row itself. And for each row, we can calculate likelihood ratio. For example, for this row, 10 out of 200 divided by 4 out of 800. So 10 by 200 into 800 by 4, that gives you a 10. For the second row, this is 24 people. So this is 24 people. Sorry. So second row, let us look at this value. For second row, it is 14 divided by 200 divided by 8 divided by 800. So that is 14 by 200 into 800 by 8. That will give you a likelihood ratio of 7. That will give you a likelihood ratio of 7. So these values are not correct. So original table is correct. So you can calculate for each row, and for each row you can get a likelihood ratio. And once you look at this likelihood ratio, you will find some particular pattern. Now look at this likelihood ratio. Remember, a likelihood ratio of 1 to 2 and between 0.5 to 1 is not at all good. So look at these values somewhere here. These values, these are non-informative groups. So if your CPK value is between these two values, you are completely uncertain whether the subject is having myocardial infarction or not. That's not at all useful. But look at these values probably. If you have a value more than 200 or value between 190 to 200, you are almost a very good result, very good likelihood ratio that will push your positive predictive value to a larger extent. Or if you have a very value like this, probably these much values. Any value between 80 to 50 to 80. That means your likelihood ratio will go down that much so that you can rule out the disease. Okay, so the gradient is sometimes would be give you a much better information than dichotomization, because they can give you for each category how much would be your change compared to dichotomization, because dichotomization will club all the categories together, and many categories with a very high likelihood ratio in the individual category. When they club, it becomes a very smaller likelihood ratio. Now you can use a ROC curve, which is basically a receiver operating characteristics curve. It started in the World War in the signal detection in the radar. Now the ROC curve is a plot where it has X and Y axis. You plot the true positive. That means true positive is basically your sensitivity in the Y axis. Sensitivity is put in the Y axis. And your false positivity is put in the X axis, 1 minus specificity. So that is curve with true positive and false positive. Now, why we use an ROC curve? ROC curve is used because we can use to identify the best or the optimal cutoff. We can decide whether the test is very good or not, utility of a test. If you have two tests and you want to compare which test is better than one, then you can use ROC curve to compare the test. Now, suppose this is how the distribution of those with the disease and those without the disease is. There is a overlap here. There is a big overlap here. There is a big overlap. Now, you may have a situation where disease is something like this and normal is something like this without an overlap. If you don't have an overlap, deciding on a cutoff is very easy. Your cutoff would be like this if you do not have an overlap. If you have an overlap, then it's become very problematic. Now, if I put a cutoff here, if I put a cutoff here, if I put a cutoff here, all the normal people will be said they're test negative, but only very few of the people with the disease would be captured. So my sensitivity will be very small, but specificity would be very high. Now, if I put a cutoff here, all the disease subjects will be captured. Your sensitivity would be very high, but a lot of normal subjects are also positive, false positive. Specificity would be low. So if you use a cutoff, that cutoff will have to make a decision about sensitivity and specificity. So when you put a cutoff, you have a true positive out of the total red curve that will give you a sensitivity. You also have a false positive out of the total normal that will give you 1 minus specificity. And as you use different cutoffs, you will have different sensitivity, specificity for that combination. And then that sensitivity, specificity combinations can be plotted in a graph. This would be corresponding to this point, and this correspond to this point, likewise. So each of these points has a sensitivity, specificity that is plotted here in this particular. Okay. So that can give you an idea about the curve. Now, an ideal test should be something like this. It goes like this and goes like this. Perfect test. That perfect test basically means the curve is something like this. They don't overlap at all. So you can put a cutoff which will clearly discriminate. Now the worst test is something like this, where the normal is something like this and the disease is something like this. They exactly overlap. So there is no discrimination between them. So you want a good test, but you don't get a perfect test. Many often you get a good test or a moderate test. If it is something like this, diagonal line, then that test is not good to differentiate between those with the disease and those without the disease. Now, how do you draw this curve? Let us draw the curve. I have just given the sensitivity and specificity. Now, when you draw the curve, you need sensitivity and actually 1 minus specificity. So this is 100 minus specificity. And this part is your sensitivity. Okay. So let us start with the lowest value, and lowest value start here. Okay, lowest value start here. So this is lowest here. So look at this value, and you need a 1 minus specificity as the next column. So that what is 1 minus specificity? This would be 100. So I'll just put 100 here. So 100 is specificity is 0. So 100 minus 0 is 100. So this is 20, 40, 60, 80, 100. This is 20, 40, 60, 80. So 100 and 100. So that is at this level. Now, next one. This would be 85. So 99 sensitivity and 85% as the specificity. 99 as sensitivity and 85 as the specificity. Let us look at the next one. 97 and this is 61. 97 and probably 61. 97, 61. And let us look at the next one. 93 and 41. 93 and 41. 93 and 93 here and 41. And look at next one. 86 and 26. 86 and 20. 86 and 26. And then 70 and 15. 15, 70 and 15. And then 45 and 7.5. 45 and probably 7.5. And then 21 and 3. 21 and 3 here. And then 5 and 0.05. 5 and 0.05. So you have a curve something like this. Sorry. You have a curve which something like this, which look very good curve, which actually look very good. So your highest values are here, lowest values are here. Okay, highest values are in the left bottom, and the lowest values are in the right top corner. Now, this is for most of the tests where more than or equal to criteria is used. Now, there are certain tests which has less than or equal to criteria, like anemia. So then the chart actually changes. I'm not going to that detail, but the chart actually changes in that situation. Now, how do you decide what should be the cutoff? Now, one of the very commonly used methodology is to calculate the optimum sensitivity and specificity. So there is something called as a Uden J index, which is nothing but your sensitivity plus specificity minus 1. And then you try to maximize this J index, Uden J index. So you calculate sensitivity, specificity -1, and that becomes the urine index for each of the cutoffs. And then you look at what is the maximum J index, and that would give you the ideal cutoff. Now, mathematically, you can also say that J cutoff would correspond to the minimum distance line, straight line, minimum distance straight line from this corner to this curve. Probably that will give you around 125, around that value. That will give you the best cutoff. So that is one way of deciding a cutoff, one way. Now, that's not the only way. You can actually think in different manner. Now, for example, now if I'm going to choose 50 as a cutoff, if I'm going to choose 50 as a cutoff. So if I'm going to choose 50, let us look at that Ella, positive Ella. 50, not 50, let us say that negative Ella, because it's a lower value. I'm going to be more interested in the negative Ella. So 1 minus or 100 minus sensitivity. So what is a sensitivity? Probably that is 98%. And what is that specificity? Specificity is somewhere around 62%. So 2 divided by 62, and that would give you a negative likelihood ratio of 0.3. Okay, that would give you a negative likelihood ratio of 0.3. So if I use 50 as the cutoff, my negative likelihood ratio is 0.03. And that cutoff will have a sensitivity of 98%, specificity of 62%. So sensitivity is very high, specificity is very low. Sensitivity is very high, basically means you can use it to rule out the disease. You can rule out. If your value, this is basically B reactive, B type natriuretic, BNP, B type natriuretic peptide in chronic congestive heart failure. So if the BNP value is less than 50, you can just rule out congestive heart failure and probably send the patient, because your sensitivity is so high, your false negative chance is so negligible, and your negative predictive value will be so high. Your LR will be so low value, so that will just push the probability of a pretest probability to a very low value, sufficiently low value, then you can know. No, maybe you can even think about this 150 as a cutoff. So if you take 150 as a cutoff, probably for a positive likelihood ratio, because this is a more higher value, your sensitivity is like, let us say 82, and specificity is 100 minus specificity is like 18%. So 82 divided by that 18 will give you around 4.5 as the positive likelihood ratio. A moderate cutoff, not very good, but probably a moderate, mild to moderate kind of a cutoff. So that you can use. Now the ROC, utility of a test is basically dependent upon the area under the curve. And area under curve, because it's obtained from a sample, you should always address that uncertainty in terms of a 95%. Now, the area under this curve would be 0.5. Probably this is 0.9. Now, what does it mean? If it is 0.5, that means it's not a useful test. If it is 1, it is a perfect test. Anything close to 1 is a good test. But what does that 0.5 mean? Now, it is a probability of giving a higher value in a randomly picked disease-positive subjects compared to a randomly picked disease negative subject. I'll tell you one more. If it is AUEC is 0.5, you have a 50% chance that a disease subject, if you randomly pick, will have a higher value than a normal subject. Normal subjects in a randomly pick ഒരു disease subject randomly pick disease subjects in a test higher value, normal subject higher value chance 50%. That means the rest 50% disease positive subjects in a test disease positive subjects in a disease negative subject lower value chance. So that's not a good test. But if your area under curve is 0.9, then it means there is a 90% chance that a disease positive subject has a higher test value than a disease negative subject. 90% chance that the disease positive subject have a higher test value than a disease negative subject. So that's good. Now, if you have 2 or 3 tests and if you want to compare the test, then you can use a set test, generic set test, with difference between the 2 area under curve as a numerator and denominator in terms of the standard error and the covariance. The standard error of difference between area and curve, which is calculated by individual standard error of the area of the curve and the covariance of these 2 curves. Now, there is something called as a diagnostic odds ratio also. What you have to know is nothing but diagnostic odds ratio is something like LR plus and LR negative, the ratio of LR plus and LR negative. Now, if you do a logistic regression, with outcome as your criterion standard, 1 for disease positive, 0 for disease negative, and your exposure variable as test positive as 1 and negative as 0. If you run this, you get an e raised to beta odds ratio. That odds ratio is this diagnostic odds ratio, LR positive divided by LR negative. Now, once you get that, you can calculate what is LR plus. You can also calculate what is LR minus based on your pre-test odds, and based on the alpha and the beta coefficient obtained in the logistic regression. Based on the alpha and the beta coefficient obtained in the logistic regression and pre-test, we can calculate likelihood ratio. And you can add other variables, other tests, so that you can adjust for the relativeness of the 2 tests. You can adjust for heterogeneity and confounding by other factors. So doing a regression can give you an adjusted diagnostic odds ratio, and that can be used to obtain the adjusted likelihood ratios. Now, the last part, I have only 2, 3 or 4 slides more, is to talk about the probabilistic nature of diagnosis. So remember, look at this scenario. Now, let us say you are a consultant in medicine. Another consultant, let us say in ophthalmology, called you. He said that there is a patient and he has a high BP. Could you please come and look at him and diagnose? Even before going there, what is going through your medicine consultant mind would be that, oh, the person is having high BP. That means, what are the probable diagnoses? People with high BP, the most common cause is essential hypertension. 95% based on their experience of what they see in their clinic. It may be 90%, or it may be 95%, or it may be 80%. So he makes a probability. He makes a feeling about that probability. Now, he gets one additional information from the ophthalmology consult that this person is a 16-year-old girl. immediately the probability value changes in the mind of the consultant, medicine consultant, because a 16-year-old person, immediately the medicine consultant, or the chance of having an essential hypertension is very comparatively less, and chance of probably other secondary causes like renovascular hypertension becoming great. So renovascular hypertension, previously it was only 5%, something like a 5% or 4% or 1%. Probably now it changes to a much larger value, 25% now. Now, the consultant went there, examined the subject, and then on auscultation, he got an abdominal bruit. Even without any examination, he got an abdominal bruit. And then with an abdominal bruit, immediately the probability changes, and renovascular hypertension, the probability becomes like an 85%. Now, with this, now the post-test probability changed from something like a 4% or a 5% to 85% by just few symptoms or signs. So it can change, even symptoms and sign can high likelihood ratios also. Now, why this is important? We want, ideally what we want is 100% positive predictive value after the test is finished for a positive test. And if you want to rule out a disease, we want to have a 0% probability of a disease. But that is very difficult. You don't get 100% probability, 100% confirmation. You don't get 0% surety that the person is not having the disease. What you generally acceptable is many often somewhere around 80% for test for the disease. So if you can raise your post-test probability to 80% or more, in most situations you will immediately start treatment. You don't investigate further. There is a second reason. If you want to change the post-test probability from 80 to, let us say, 90%, the likelihood ratio for that test has to be so high, and it is very difficult for a test like that. But if you want to change, let us say, a pre-test probability 20% to probably 80%, the likelihood ratio has to be like maybe like a 10 or 15, etc., and then it will change like this. So any test, when you use, you should think about what is the post-test probability. If you do a test, if that test can shift the post-test probability to a very large extent, then that test is useful. That is where the initial statement I put by the Archie Cochrane, that if you plan to do a test, think about if you get a positive result and if you get a negative result, what you are going to do. If your answer to both the reason is nothing, same, then there is no point in doing it. Because if you get a positive and negative and then your answer is nothing, then there is no point. If you get a positive result, your answer is I will be testing, or I will be treating them, or I will need a further test. If you get a negative result, your answer should ideally be I can just release the patient, or I need another test to say that this is confirmed negative for that disease. So use the appropriate test to increase the probability or decrease the probability based on the likelihood ratios of the test. And most of the tests work very good when the probability, pre-test probability or the prevalence is somewhere in the intermediate range, as I have mentioned before, between 20 to 80%. If the prevalence is low, don't use the test, but use history and other examination, other things, etc., to increase the pre-test probability to somewhere around 20 to 30%, and then apply a test, so that your post-test probability will cross over to probably 70 or 80%, etc. So, in summary, we said predictive values will give you an idea about post-test probability. And we said predictive values depend upon the setting, how the subjects are selected, these things affect the prevalence, etc. We said likelihood ratio is a good indicator of the goodness of test, whether it's a binary test, result given is a test as a binary or ordinary. Now, ROC curve can be used to help decide the cutoff if your test gives ordinal or a continuous variable. Or ROC curve can be used to choose an optimum test if there is more than one test is available and you want to choose the best optimum test. I think that's all. If you have some questions, please do ask. So I have given my email ID. If you have further queries even after this session, you can just mail me also. So if you have some question, please do ask question. I know that I have overshoot a little bit extra time. I was expecting it to finish probably by around 1 hour 20 minutes or 1 hour 30 minutes, but I think we overshoot by at least another 20 minutes, 1 hour 30 minutes more, 30 or 1 hour 40 minutes I have taken.
That's okay, sir. Does anyone have any questions?
Session kaduthu poyo?
Sir, illa sir.
ചോദ്യമൊന്നും ഇല്ലെങ്കിൽ എനിക്ക് തോന്നുന്നത് നിർത്താമെന്ന് തോന്നുന്നു.
Okay, sir. So we are ending our discussion session here. Thank you, sir, for being a guest in this webinar series. I'm sure that the session was informative and it was quite extensive session. You have covered almost most of the things that we wanted to know. Thank you everyone for joining us here. Gentle reminder for the last session. Our last session is planned for next week. Topic is choosing the perfect screening test during pandemic by Dr. Anish T.S., Associate Professor, Department of Community Medicine, Government Medical College, Thiruvananthapuram. There might be a slight change in the schedule for the same. Please keep an eye on your mail. We shall inform the schedule at the earliest. Your feedbacks are available, so kindly fill the form, send in the comment box. See you all next week. We wish you all an enjoyable weekend. Thank you.